One of the things that you say, Kavi, and is music to my ear, because I've been trying to do that at the University of Minnesota for many years, and that's following the Japanese technique. Dr. Miyayama, Dr. Tanaka is here, using smaller microcatheters for TACE. And of course, when we started first to show at GEST, at the time of COVID, using this microcatheter, smaller, pushing without wire, a lot of people started to text us and say that's a crime, you should not use microcatheter without wire. Just wanted to ask, how many of you actually use this technique, just to advance small microcatheter without wire? How many things is a crime? How many things that you have to use a wire? Sid Padia would be here, who would say, no, I have been taught that I wouldn't use wire, I shouldn't use wire. Anybody is convinced that you have to use wire for every microcatheter? Okay. So there are, when I look at Okuno, I don't know how he does with Volute, every single catheter vessel he can go without wire. But when you can't do that, and I have been in one case, you use micro wire. What's your choice micro wire in those situations?
So we usually use a Meister.
Meister.
Asahi Meister microcatheter. I think the torqueability, one-to-one torqueability is very good, and also the reshapable, and yeah, it's very good.
Very good.
Yeah.
First, any question from the floor? Because I think having these experts here, it would be good to have some interaction. Any question? Kumar?
Great talks, guys. So are we done with the Imipenem concern for resistance in the U.S. at least? I know Japan, it's easy to use, but Oz, Kabi and Jafar, I know this is still something we think about. We talked a little bit about the data or research. Are we clear for fear Imipenem usage without concern right now?
Using Imipenem without concern?
With the resistance concerns. Are we clear from that now?
I will let you comment, but I will give you my opinion. I am using Imipenem, but I will give you my opinion.
I don't know if this is working. Oh, it is. Yeah, no, it's a really good question, Kumar. I mean, I think the reality is you know, in the position statement, we have mentioned Imipenem as a, you know, embolic that's used for GAE. It's probably the one that's been studied the most, right? I'm not aware of any data that suggests that there is increased antibiotic resistance. I don't know if it's because of the amount that we're using or whatnot, but I do think that whether it's a real concern or not is the impetus to evolve beyond it, you know, to other embolics like resorbables that kind of have similar functions. So similar to Jafar, we do use it. I think we use primarily Lipiodol now because of the breakthrough designation and just obviously just it has similar efficacy and safety data. But whether it's safe or not to use, you know, I think there's really no hard data on it one way.
Yeah, we published at CVIR last few months ago a review on Imipenem, and there is no data, but I have a serious concern that there is a risk because there's a very strong antibiotics. But the data going back to 1991 that has been used in Japan, and we look at literature, we look at a lot of publications. We haven't seen any data confirming that, and it needs some animal study. And I heard that there was an animal study done in France. They have not published it. But what they have seen is that within 24 hours, all of the gut biome were dead. And that can raise a concern. So we can't extrapolate the animal data with one study that is not published to this, but I still talk about that as a serious concern.
Yeah, I'll add the only way that I was able to get Imipenem on my shelf was it was a 2-year runway until other resorbables came. And that 2 years is almost over. And so I've, like Oz, have switched to mostly Lipiodol at this point, or Lipiodol. But that was the only way, showcasing, you know, whether we agree with it or not, the low risk of permanent embolics, and then using that as a mechanism to have on the shelf.
Lipiodol, you say there's breakthrough indication for knee embolization? Mm-hmm. Can you expand on that a little bit? Should be open.
Oh. Did you read the paper that you're co-author on?
Well, it's for people to listen to hear. If I ask the question for which I don't have the answer, I should sit down. It's like my modesty. Go ahead.
You got to give it to your big brother whenever you get a chance, you know. So so no embolic in the United States has an on-label indication for musculoskeletal embolization. In theory, we're using every single device off-label for embolization in GAE. A few of the products in the U.S. have what's called a FDA breakthrough designation, which doesn't mean it's on label, but basically means that the FDA has identified that this is a high priority thing, and that they're sort of supporting sort of fast-tracking studies to sort of understand that. So along with Lipiodol, I believe Embozine does and Embosphere does, and then Nexphere and CranMed are both currently enrolling, or CranMed's is done, but they're doing IDE studies for on-label indication. So there's basically 5 embolics, that are kind of in the works.
Yeah, we'll talk about that actually in the next session on the master class. So Yuji, I feel that there is a shift in your practice for plantar fascia, because but your paper that you published, you said at the beginning you did intraarterial, then you switched to direct puncture, and now you are going back to intraarterial, selective catheterization, and direct puncture is only after you failed before the first one.
And for example, for knee or elbow, it is very obvious that super selective is better, because we cannot achieve the same packing density when we do the direct puncture method, because the target vessel is little bit far from the popliteal artery, from each genicular artery is very far. So we strongly recommend to knee OA patient to receive super selective GAE. But for the plantar fasciitis patients, maybe we can have some space, like your institute do that multiple embolization in a single session. We can improve more, better single super selective embolization better. But when from our initial experience, the direct puncture results is good for plantar fasciitis, because
the average procedure was 2.3
single
per patient.
Yeah, single is not enough.
Yeah, because I think Amin presented that, and we talked about that on MSK Day on Sunday. We switched to a technique where we embolize from PT, and if we wait 5 minutes. After 5 minutes, if the blush is back, which is back almost in 85% of cases, then we go super selectively and embolize until the blush doesn't come back. And we saw that the recurrence rate is much lower.
Yeah, and now we are switching from Imipenem to the other resorbable, in many reasons. But in Japan, the Imipenem is too much cheap, because the government sets the price, and it is about $6 for one buyer.
Japan is FDA, from what I know, is not the hardest in the world. So you don't have any limitation to use Imipenem as an embolic?
In off-label use, and in so our practice is self-pay practice. Yeah. So government insurance doesn't cover. Okay. So we can use that in that off-label use, but but recently we switched to the Sakura beads. We began to do the direct puncture for plantar fasciitis with using Sakura beads, and the results is good. So I think maybe
And then one question for any question from the floor, by the way? We have just 2-3 more minutes. Go ahead.
How do you decide direct puncture versus the catheterization? It seems like direct puncture would be...
How to decide between direct puncture or catheterization?
It's faster, easier, use less material,
main reason is the financial aspect. Patients have to pay by themselves in our country.
So direct puncture, I don't know in the US, anybody knows if we do direct puncture and inject embolics, is it considered embolization or not? That's one question. It could be because you're injecting something to close something, but so if you explain to the patient that from the data published by Okuno, you can do direct puncture, but the chances that this patient has to have an average of 2.3 intervention, so you may explain to them and you may come back and do this again, then I think you can definitely do that because that data is very convincing. Now, for our patients, we prefer to give them one shot because we don't know if they are going to come back, or they will probably not prefer choosing a puncture there instead of a puncture back there. I don't know. It's the discussion. It seems that if we do intraarterial, you have much less chance of recurrence. Any other question? Last question.
Is it really working out if patients have to come back for what's called embolization with direct puncture 2 to 3 times? Does that really work out more cost effectively?
Can you repeat the question?
Yeah, so if your patient's
Cost.
coming for 2 to 3 times on average for a direct puncture versus intraarterial catheterization, is it working out financially beneficial?
Oh, the question was if the patient comes and has more puncture versus intraarterial catheterization is financially going to be more beneficial for
Yeah.
those patients.
Yeah, so it's we have to examine that. Yeah, so we yeah, so we set so it depends on what price we charge. Yeah, and
Yeah, I don't know in the U.S. what honestly I think we should ask that question from those lawyers that were here at the OBL session. But it's a good question. What do we charge for a direct puncture? But anyways, none of our patients in the U.S. can afford to pay out of pocket for any procedure anyway. So I would like to thank you guys for a great presentation. Thank you for all of you who stayed here. Thank you, Asai, for an amazing session.